All right. Hello, my name is Christy Cox, and I'm really thrilled to be here today with two pioneers in the Ehlers Dominos community. And we're honored to be speaking to the EDS Awareness and Chronic Pain Partners group. So thanks for joining us after your recent research paper that came out that we're going to talk about today. But first, let me do a quick introduction of you two. So Leslie Russek is with us today, and she's a PT and DPT, PhD, OCS, ABC, just kidding, and Professor Emeritus of Physical Therapy at Clarkson University. And she's an orthopedic certified specialist physical therapist with over 30 years of clinical practice and 25 years working with patients who have hypermobile EDS. She's coordinated research and has clinical interests in this and fibromyalgia, headaches, chronic pain. And she's presented nationally and internationally on HSD and HEDS. And so we're really honored to have her here with us too. And our second guest today is Susan Chalela, who's an MPT and the founder of Chalela Physical Therapy Institute for EDS and CCI cervical instability, which is outside of Charleston, South Carolina, and why I'm here today to get ready for my appointment for my neurosurgery with the care team at MUSC. And I'm looking forward to Susan's going to take care of me after my surgery, as she takes care of a lot of EDS patients. She has over 20 years of clinical experience, and she's been involved in all kinds of domains, including like orthopedics, sports, outpatient, aquatic therapy, ergonomics, and neurological rehabilitation. And so her passion is to help hypermobile patients. And she works closely with Dr. Sunil Patel from MUSC on patients that come out of CCI and EDS related spinal complications. And, you know, both of these ladies actually suffer from this condition themselves. So they are fellow zebras. They get it and they understand how we are and how, you know, our needs are different. And thank you both for being here today. And I'm really thrilled to share the exciting news that you put out in your recent research paper. So Leslie, you want to give me a short summary of, you know, what the findings were on the paper and explain, I know it's a different acronym that your guys are talking about with UCI as opposed to CCI. So want to tell us about that?
Yeah, and first I want to clarify, it's not actually a research paper.
Okay.
So we didn't collect data for this, but it is an expert consensus paper. So there really isn't research on upper cervical instability in patients with hypermobility. And what incited me to pull this team together is the fact that we have expert clinicians, people like Susan, who have a tremendous amount of experience working with this population. And even though we don't have research, there's a lot of knowledge, and we needed to pool that knowledge and share it with people who didn't have the opportunity to learn directly. So it's an expert consensus, and it is an international team. So I'm pretty confident that this is the best knowledge we have in the world on this particular topic at this time. And hopefully it'll inspire some research, and in another 10 years, we'll be able to talk about an actual research paper. So the article provides both providers and patients who have upper cervical instability and hypermobility spectrum disorders, hypermobile Ehlers Dominos, with a framework for screening and managing upper cervical instability. And we did use the term upper cervical instability. It is in the literature. We felt that that was more inclusive of both CCI, which is technically craniocervical instability, or the top vertebra and the head, and AAI, or atlantoaxial instability, which is the first and second cervical vertebrae. And there are some differences between instability, CCI, and AAI, but in terms of management, there's a lot of similarities. So we grouped them together, and we felt that the term UCI included both CCI and AAI. So research suggests that mild UCI can be a very common condition, and literature suggests that up to 66% of people with hypermobility may have some mild symptoms of upper cervical instability. And severe upper cervical instability is not very common, thank goodness. Maybe only 5% of the population of people with hypermobility, but it can cause a lot of disability. And so it's a really important group, even though it's not including as many people. There aren't any published guidelines or research regarding non-surgical management of UCI. So there are some papers on surgical management, but nothing for conservative or pre-surgical or avoiding surgery management. So the article combined the knowledge of hypermobility experts from 3 continents, so the US, England, and Australia. We outlined a basic way to screen for UCI based on the patient's symptoms and history. And we had a 3-part criterion, so the symptoms should look like UCI. And we divided that into musculoskeletal and neurological, and I'll talk about that when we go through the patient handout. The symptoms are altered by neck movement or position, and this was to help us distinguish between symptoms that are due to UCI and symptoms that could be due to other conditions that are common in hypermobility, like dysautonomia or mast cell activation. And then finally, that the symptoms are irritable. So the symptoms for musculoskeletal cervical instability, so that is pain is due primarily to the muscles and joints. And we felt that was easier or had more successful management. And then for patients who have neurological UCI, where there are some neurological symptoms due to stress on the spinal cord, brainstem, or cranial nerves, was a bit more challenging to manage. And patients can have both, and they can switch from one to the other. So they may have mostly musculoskeletal, have a flare of more neurological. The article recommends screening for yellow flags that can interfere with management. So yellow flags are psychosocial issues. And we know that psychosocial issues can make it more challenging to manage any kind of medical condition. But it's really important to recognize that yellow flags can amplify the disability and make it harder to treat, but it doesn't diminish the possibility of a mechanical instability or the very real physical problems that underlie it. The article also recommends screening for red flags that can suggest either severe upper cervical instability or other conditions that should be assessed and ruled out or referred to an expert for assessment. And then we recommended using information about irritability and severity from the history and symptoms to identify what physical examination tests are likely to be safe and not likely to cause a significant flare. And that, I think, is a really interesting insight. Previous models that talk about decision-making and physical therapy, I've never seen that before, where you use the symptoms in history to decide what tests are safe to do. And I think that's because these patients are so easily irritated that if you do just simple things like neck range of motion, you can make them worse. And so the group felt it was really important to identify what tests we shouldn't be doing. So the tests we grouped into 3 tiers, ranging from least likely to be provocative to most likely to be provocative. So those most likely tests you wouldn't do on somebody whose condition is really irritable. And then deciding how irritable the condition is based on the both subjective and physical exam. And the article suggested 3 tiers of management, with the most cautious interventions for those with the most irritable UCI, and then more aggressive interventions for patients with milder UCI. And of course, people move on that spectrum. We hope that patients who are doing well will go from having an irritable UCI to having a milder UCI. And so hopefully patients will progress through those different levels. And then the paper includes 3 case studies, one with high, moderate, and low irritability, that demonstrates how we use the model and how we might implement a patient care plan. So it's an expert consensus, but it does provide us with a lot of hypotheses that research can test. And it definitely has raised awareness for UCI in this population. We're super excited that the articles had 21,000 views so far, which is really exciting.
I was going to say, as a patient, we're very grateful to all of you that participated in this and, putting together this information, because for a lot of us, the basic question is, how do you know when it's time to get surgery? Can you treat it with PT? And we'll talk in detail about that. And sorry, Susan, if I cut you off there.
Oh, no, you're fine. You're fine.
Go
Do you want me
ahead.
to go ahead with that question?
Sure. So before we get started, thank you again, and as always, this is kind of a disclaimer. This is not medical advice, and you should always consult with your physician. But one of the things that, and we'll share a copy of the paper when we publish this article, and more thousands of people will go and review it, because it is so helpful and written in such an easy to understand way for the patient to be able to navigate through. Okay, I have these red flags, or I have these yellow flags, and what do I do about it? So it's really terrific and quite groundbreaking. But rather than kind of go through and review the research paper, one of the things that was really helpful that your team did was put together a patient guide that sort of talks through, if you're HSD or hypermobile, or EDS, helping you kind of navigate your way through this. So if we get started on the questions, you guys want to tell me, like, how did this large international group of hypermobility experts come together to create this body of knowledge?
Yeah, so it actually started like almost 3 years ago. There was a team of doctors on the West Coast that wanted to create a protocol for using cervical traction to treat CCI, so stretch in the neck. And they invited me. I don't know how they got my name, but then I invited Susan and the others who participated in the paper. And we were kind of appalled about the traction, that yes, it may decrease your symptoms, but it may also make your instability worse. And so the PTs felt like we had our own things to discuss. But I felt like it was really important that if I wanted to facilitate a discussion, we needed to do something with that information. We needed to share it with someone. And the US is really, it's really an EDS desert for knowledge and research compared to places like London, Europe, Australia, where they have these specialty clinics that have researchers and a bunch of doctors and providers who all work together. We don't have that network in the United States. And so I wanted to pull this network together, but I also wanted to do something with the information. So I contacted Alan Hakim, who's the educational director for the Ehlers Dominos Society, and asked if that's something that he thought could be publishable. And he did. And he suggested that we invite an international team. And so we invited a number of people who are affiliated with the Ehlers Dominos Society, and the ones who chose to participate, a group from the London clinic, and then a group from Australia and the Sydney clinic. So that's how we got the international group together. And then we spent about a year and a half talking back and forth. We had Zoom meetings, we had online asynchronous meetings, we had a couple of surveys, SurveyMonkey surveys to rank symptoms and signs and figure out how we're going to put the information together. So that's kind of how it all happened.
That's great. Well, again, we're so thankful for it. So as you mentioned, this UCI information is really making waves in the patient community. And, you have had the opportunity for us to make it, publicly available, free access, which is sometimes an issue when, there's information that comes out, we might not be able to access it. So, we appreciate that as well. So,
and I want to have a shout out to the Ehlers Dominos Society, because they're the ones who funded the article to allow it to be open access. And Dr. Hakim facilitated that. So it's thanks to the Ehlers Dominos Society that it is available to everyone.
Yes, absolutely. Thanks to the society for certain. So what was the most, like Susan, maybe tell me what was the most exhilarating or maybe the most exhausting part of doing this big multi-year project?
Oh, wow. I think just finding the time to really, get together and Leslie handled this very, very well because she was the ringleader on all of this. So she would take one section at a time and we'd concentrate on that. We discussed that. And sometimes we couldn't all be together because of the time zones. But we would discuss it within our group. So like within the US group, Leslie would bring us together and we discuss, whatever it is, that we were talking about, we were working on, meaning, either presentation or conservative treatment, how we thought about different things. So, it's just trying to make that effort to really get together and discuss this and talk this out was probably that for me, because I'm so clinically, clinically oriented in the sense that I see patients, 5 days a week. And, it's hard for me to find that time, but I did at night and I did on the weekends. And I think that's all of us, we all kind of working that way and working hard. But it was exciting because it was something that Leslie could pull together and could pull all of this information together between all three groups. And so, wow, now it's out. And this is just the beginning of what needs to be done, research wise and clinical wise, and to teach other PTs how to do this, because there's still this whole, perception of traditional physical therapy treats these patients fine. And really, when you get to the neurological aspects especially at the upper cervical, the brainstem aspect, the dysautonomia aspect of all of this, it gets complicated. And traditional physical therapy just tends to make, these symptoms and these problems worse. And we have to be very careful, with this. And so it's going to be important over time for us to get the clinical information out there of what really works specifically, so
Yeah, and what not to do.
And what not to do, exactly.
Yeah, that's a great point. I know from my own personal experience, if you see an unaware physical therapist, they're going to do like traction and, like a lot of manual work, and it just exacerbates things. And, it's one of those lessons that you learn the hard way. And you don't know why medically or clinically, you just know you feel worse. And so, it's like, maybe let's not do those things.
You do. And the red flag there is, while you're doing it as a physical therapist and you have your hands on the patient, especially in the neck area, soft tissue wise, traction wise, that patient could be telling you that they're feeling great. Like, wow, this feels great. I feel great. And you're thinking, oh, I could do a little more. I could do a little more because they're feeling better. But then it's the after effects of relaxing or releasing the backup stabilizers to the faulty, the primary stabilizers that aren't able to do their job. And as soon as you kind of turn off, the muscles that are your backup system, because, traction again unweights, the pressure on the nervous system and weights the discs. And of course, we're going to feel good temporarily, but it's the after effects that creates. In turn, it does more damage. So we're seeing this, happen. So yes, the patient may say that they feel good, but there are little things that, do work clinically for these patients that we've found out over time. And so, that's what we need to share. That's what we want to share, because we've been there, done that. We have hurt patients, not intentionally with our traditional, ways of treating, but it's very, very important to realize that you've got to listen to who is doing what clinically, because we are finding what's working and what's not working. And it's not always what you think. So
that's why this is so important. And, as I mentioned, a really valuable piece to me as a patient, with me having surgery in 3 days on this particular issue, is, your patient guide, which is called the Upper Cervical Instability and Hypermobility Spectrum Disorder. And we're going to be sharing that. But, let's go through, let's dive into the patient guide. Leslie, do you want to kind of explain the difference that you guys note between instability and hypermobility?
Yeah, and that's a really important distinction, that we may be born hypermobile, but instability is something that comes and goes. So hypermobility means too much range of motion. Instability, on the other hand, means you're not able to control that motion, that the muscles and the nerves that go to those muscles aren't able to maintain stability, especially in mid-range or neutral ranges. And so we may be born hypermobile, but we have some control over instability. And that's where physical therapy is really powerful in retraining the muscles and the neuromuscular control, the proprioception or body awareness. So we can't stop being hypermobile, but there is the potential for physical therapy to make us less unstable. And if we have a flare, it's a flare of instability. But again, we may be able to control it. And in many cases, of course, patients can control it and don't need surgery. And that was the group that we were really targeting.
Yeah, so, I want to make sure that we talk about that, whether it's now's the right time or not. But, it's that question of, can physical therapy get me through this? How do I know when it's the right time, for me to have surgery? People ask me that all the time. Like, how did you know? Any insights on that you guys want to share?
Susan, you want to take that one?
Sure. We'll definitely take that one. So, we always start. So when the patient comes in, we get a history, we get a physical exam. And so they're going to present with all of these symptoms. And what do you do with them? My biggest thing is equating all of those symptoms, my physical exam, and then on top of it, what does your function look like, and what is your pain level? So when we're looking at function, I realized over the last 6 years that some of these patients who come to me and say, oh, my imaging shows that I have severe cervical instability, and I have all these symptoms, but yet they're working a full-time job, they're struggling, but they're working. How can we better assist them? So you have they may be like a moderate irritability just because they're living with this, but yet they're able to function. So for me, I'm always looking at irritability status with function. And again, what's the patient's wishes? Because many of these patients don't want to be fused. And so what can we do to support them? Supports, bracing, strengthening, how can we help them manage all of this to be able to live a more functional life? Then we have these patients, and again, they can come to me and say, my imaging, I've been told I have mild instability, but they could be a patient that is housebound and in bed an awful lot and really feel that they can't work and they're not functioning very much. That's the patient that, really needs, physical therapy, not aggressively, again, just, guiding them through to support them, to see how well we can support them to get, their function back. And so that's the biggest thing is if I have a patient and I have a way that I work with my patients and strengthen them and educate them and help manage them. And I do a lot of education. If they're going through this process and they're still super irritable and very symptomatic, and we just can't get that under control no matter how we try, and they're not functioning, I leave that up to the patient, but the patient at some point, they're not going to be satisfied with just living this life in this very low functional level, and they're very symptomatic and they've tried absolutely everything, then they're the ones that tend to choose, to go the fusion route. And by the way, sometimes it's just a matter of releasing a tethered cord, because more than likely many of these patients have a tight spinal cord that causes a lot of other irritable neurological symptoms. And what we're finding here is, if the patient's cord is being detethered, we are finding about a third of those patients their symptoms of their upper cervical instability are improved. And that's huge. Yes, it's only a third, and it's just clinical evidence, but we're hearing that. And that's, sometimes that's worth that risk because, again, when you're hypermobile and you have an unstable spine, you're constantly kind of irritating your nervous system. So again, it's, I really spend a lot of time with the patient, helping them talk through all this, work through all of this. And ultimately it's their decision, to make that decision. So it's really having good guidance from your medical team and your therapists and knowing that you've tried everything that you could do, before you get fused. Because you have to keep in mind a fusion, again, you're putting metal in the body, screws, plates, rods. And when you're accepting that into your body, it's only as good as, again, it's like a workshop. It's only as good as those screws hold. And do we see loose screws, or do we see metal allergies? Yes, we do see there are those risks. So you want to always keep that in mind too, because it's not a quick fix. And it's surprisingly, I do get those patients that come in and say, I think I'd just rather be fused now because I have these symptoms, and go get fused and then come back and do physical therapy afterwards. And I very much guide these patients that on the front end, gather as much knowledge and information on the management side prior to that you can tolerate, that you can do, get yourself to that highest level of capacity in managing this. And then if you have to undergo surgery and be fused, then coming out of that, you already have all this knowledge. Coming into surgery, being as strong as possible is most important, because then coming out, you're going to start back in the beginning again, but you're going to, flourish faster, and you're going to manage better overall. So I guide my patients to always keep that in mind.
Yeah, I know in my personal
something.
experience, I'm sorry, in my personal experience, it wasn't necessarily, most people think that it's like pain related that puts you at that point. And my personal experience was not that. It was the neurological issues where, your loss of ability to like walk a straight line or complete a sentence that was like, okay, something is not right here and we need to look at surgical intervention. Sorry, go ahead, Leslie.
No, I wanted to add to what Susan said, because she was talking about patients who are very disabled or maybe bedbound. And that's where our model has those yellow flags that we want to address, the psychosocial factors. And again, it doesn't mean that they don't have cervical instability, but people who have a lot of psychosocial factors, so let's say a history of trauma, or very stressful life experiences, they tend to not do as well with medical care, both surgery and conservative care. And so this is why we recommended that people get co-managed for those psychosocial issues to improve their prognosis, because sometimes people who have a lot of these psychosocial issues aren't going to get better with surgery either, because of the neuroplasticity of the brain.
Yeah, I completely agree with that. That's so important. I think as a group, Leslie, when we were discussing this, as internationally with our big group, I remember in the very beginning really stressing, the number one aspect is the psychosocial part has to, be better under control to really, get your best outcome. So I agree.
So your paper goes through a lot of both the musculoskeletal and the neurological symptoms to look for. And I don't want to spend too much time talking about that today because they can read that. Let's get into, what are the things that you guys call mechanically irritable, and that's, where you're aggravating this area of your body with certain activities and, things that cause a flare. Any guidance on that?
Susan, do you want to take that, or you want me to?
Go ahead, Leslie, and then I'll kind of chime in.
Okay. So yeah, mechanically irritable was important because so many of the symptoms of UCI overlap with other problems that hypermobile people have: dysautonomia, mast cell activation, brain fog, poor coordination at their joints. And so it was important to determine that it's the upper cervical spine contributing, is that it be mechanically irritable. So it involves, hang on a sec, that movement can make it worse, or your posture, bending forward, things that put stress on the neck would aggravate it. So there has to be something mechanically associated with the neck that aggravates it. So it's not just, let's say, dehydration or eating a high histamine food that aggravates your symptoms, but something associated with your neck. And then we divided people into 3 levels of irritability: high irritability, moderate, and low irritability, based on their symptoms and their history, so that we could decide which tests were going to be safe for them. We talked about that, how it's really important that we don't make these patients worse by doing standard physical therapy tests with patients who might have a high irritability. But I think having these 3 levels of irritability also allows people to see sort of where they are on the spectrum and if they're getting better or getting worse. Because we're not stuck at a certain place, that hopefully with treatment you get better, and possibly if things are going badly, you may get worse.
Susan, anything to add?
Yeah, I mean, that's exactly, what we did, and super important that as physical therapists, because that's what we are, we don't diagnose, but we do look at, presentation of the person overall, and we look at all of the comorbidities that come with, EDS, and all of that affects the patient functionally and again, so psychosocially. So looking at, the whole person. And then again, what I really liked, the way that they, the group came through and said, well, let's, instead of looking at mild, moderate, and severe upper cervical instability, let's look at it as irritability status. Well, that makes sense on the physical therapy level, because what affects your function is your irritability status or your symptoms, your neurological symptoms. So, weakness, motor dysfunction, being able, coordination, with your walking, with the use of your arms, things like that. All of that comes into play into that disability status. So we're looking at that stuff and how can we better support that patient, bracing supports, wheelchair, get them more mobile, get them more upright, functional, but again, keep them as less irritable as possible. So if they come in super irritable, our goal is to, once again, look at how they present, and then how can we teach them to make changes in their posture, in their alignment. And then once they get to their alignment, then we can start strengthening. My whole thing is you've got to look at the foundation first. And traditional physical therapy has you looking at the upper area when you have neck pain and when you have problems. So, we always go right to the neck and treat that, or maybe the scapulothoracic shoulder area first and then neck together. But for me, what I found most successful was really looking at the foundation of this machine, this human body. And, if you're hypermobile and we've got 360 joints in the body and we've got all this movement, how are we going to get control over all of that? But what we do know is we feel through our body proprioception. We feel where we are in space, and being hypermobile, we do that very poorly. We're very clumsy. We tend to be off balance more so than other people. We walk like very poor runway models. So how can we get control of the dynamic or the movement mechanics, right? Not only the static postures, but then also we have to move. We have to live life. What do we do during the day? We, sleep and lie down. We sit, we stand, we walk, then lift, carry, bend. How can we support these patients to best protect their alignment of their neurological system? Okay, so as a physical therapist, that's what you have to think. So again, even though the base of the spine starts at the pelvis, and that's critical nervous system, we still have to look at what the feet and ankle do, because feet and ankle have a lot of bones, a lot of movable parts. And if we're not supporting these collapsing arches because of all that hypermobility in those bones and joints, then the movement's going to start at the foundation, and you're only going to get more and more movement up the chain. So to stabilize, you have to first look at the foundation, build more stability, and then look at each component above until you get to the neck. How can we better support and decrease the amount of movement and increase control. And remember, this is a faulty ligament system, so it's a structural system where your ligaments connect bone to bone, and, they tend to be faulty. So your only backup system that you have are your muscles. So that's where physical therapy is so important. So does that mean get into traditional physical therapy or go to the gym and do a bunch of, gym exercises, and so that's a misnomer. I mean, we've got to get a hold of our body statically first before, and then work on alignment, and then, build that more functional, healthy movement system. So again, in turn, that decreases irritability typically. I mean, most patients, we can get them to bring their irritability status down. Now they could have a flare, something could happen. A flare could happen because of mast cell or because of your dysautonomia or a comorbidity, or it could happen with a motor vehicle accident or a slip or a fall or, something. And again, that's going to bring your irritability status up. Does that necessarily make your upper cervical instability in imaging worse? Possibly it could if it was traumatic, but the biggest thing is being able to get a hold of that irritability status and help that patient to manage and bring down that irritability status. And the more that they get under control, the more that they have tools in the toolbox, they know what to do, they know where to be in space, that flare they'll bring their flares down faster. The problem is when patients get into flares and they don't have these tools, they tend to make their flares worse, or there's flares that irritability status sits there for a very long time. Because what do we do when we don't feel good? We go into fetal position, or we slump because it feels so good for that moment. But the problem is it does put pressure, in stretch and compression on the precious, critical nervous system that in turn actually makes us worse. So we're always looking for something to make us feel better that most of the time isn't what we need and tends to keep us in that flare longer. So this was I was really excited, about the way this made me think a little bit about the management of my patients and how to manage them. So,
Yeah. So real quick, I want to go to I know that you guys don't diagnose, but what kinds of physical exam or tests and things can you do to help aid a patient trying to figure this out? And then I'd love to dive into what you're talking about, Susan, about, what are these strength building things that people can do to improve their quality of life. So Leslie, you want to tell us a little bit about the the physical exam and testing?
Actually, I'm going to let Susan do that. She's more knowledgeable about that.
Okay. So when I first see a patient, the most important is I first look at the history and symptoms. I listen to my patient. I spend a lot of time listening to them. So you're listening to, what's their pain level? How do they function? Do they have headaches that are worse with kind of a Valsalva, maneuver, like when they're bow mostly, when they're pushing. I want to hear that their bowel and bladder system is functioning, normal, but a lot of times, we're hearing in our more severe patients that it's not. You've got things like brain fog. A lot of these patients have a hard time concentrating, and you want to hear all of that. Ears, eyes, so hearing, you're going to hear things like tinnitus, buzzing in the ears, swishing in the ears. You're going to hear in certain positions, you're going to hear, maybe, eyes kind of in spasm, or double vision, or just blurry vision. You want to listen to every little detail, because even if you don't think something's related, a lot of times we can circle it back to it being related in one way or another, or at least to postural, their poor postural alignment. And then find out what their function's like. Are they, sitting around the house and not doing much? Are they in bed most of the day? Or are they very active with their job and they're just pushing through? You want to know that. On a physical examination side, we're looking at, you have to be very careful with that. So you have to get that, you have to hear first what's going on. And then in your mind, you have to be very, very aware of what category, what things can I look at when I'm doing the physical examination? Because if you're hearing red flags, if you're hearing that they're very, very irritable, you got to be very, very cautious. I tend to be, and I think in our consensus, we agreed to be more hands off with these, these more severe patients, and looking at things like what's their posture look like, while they're either sitting in a chair or lying down. Sometimes a lot of my patients will lie down if they're very irritable. What do their muscles look like? A lot of times they'll be up here with their upper traps up in their ears, kind of trying to hold their head up if they hadn't come in collar, as of yet. We're looking at the way that they walk, the way that they stand. So, if you can get that, and then, or the way that they transfer from their wheelchair, all of that is like super important to know what's going on. Then we can do things like neurological testing. So we can look at cranial nerve testing. We can look at Babinski. We can look at Hoffman. If they're positive for that, back off on all the hand stuff, because that, the hands-on stuff or the manual stuff, because that, this person's going to be, very neurologically symptomatic. If they're walking and if they're walking with like an ataxic gait and they're very, uncontrolled poor motor control with their walking. And it's funny, I can have like not a very painful patient, but their walking could be absolutely scary, balance wise. I would put them into the red flag, even though maybe their pain, and they're not telling me their pain is really severe, but I just noticing that that's neurological, it's a big neurological sign. The other thing is, also look at, you can do some light palpation with these patients to kind of see and feel how their muscles are reacting and what they're doing. Look for spasms, look for, the tone of their muscles in general. That's fairly safe. The other thing is, sometimes if they haven't had any experience with a collar, I have a number of collars in my office, and I'll find something that can kind of fit them, and we'll put them in a collar trial while they're sitting there, and they're upright. And it's really surprising. Some of them are just like completely relieved, and we're like, wow, my symptoms have really, gone down just because I have that support. Other ones you're going to find that are more irritated by the collar. So they're all signs to look at. They're kind of your very irritable patients. That's how I would start. And then I would start with maybe diaphragmatic breathing, vagus nerve, bring down that level of just their heightened fight and flight system in the beginning, but do it in proper alignment. So get them, get them on their back, teach them supine hook lying, or support their knees, upright. Teach them how to find neutral pelvis and to learn how to breathe just the normal breathing status. And so there's a lot of things that we can do with these patients in that, at that time. The moderate to lower irritability patients, if I'm hearing and they're sitting there and they're moving around, I'll go ahead and I'll assess, neck movement, scapular movement, jaw movement, anything kind of up in this area. I've already watched them stand and walk. And, so now let's look at this specifically and see how they do. So I will look at their control, of their movement. I mean, some of my floppy teenage patients, they'll just throw their chin to their chest and throw the occiput back to the, their thoracic area. And it's like, wow, that's some movement. And so then I'm educating them right away not to do that, not to flail their head around, because they, when they're young and they have all this hypermobility and, they think it's cool, to show you all that they've got. And so at that point in time, I jump in and I educate. And I think that's super important. So motion control. The other thing is look at the neck muscles. These days we've got computers and cell phones. So what are all these kids doing? The teens, the 20s, even the young ones, I'm getting a slew of younger ones, 7-year-olds, 8-year-olds. And what are they doing? They're looking down on iPads all day. They're looking down on cell phones. They're looking forward, or they're reading and writing, over a desk. But that forward head translation, that forward head position, over time accumulates to the damage of the pressure on that, the upper spinal cord, brainstem area just by being in that position. So right there, I jump in and I educate right away on the use of prism glasses, lazy readers, stands, use little iPad stands and cell phone stands to bring the level up to, the head and the eye level so that the patient isn't looking down. So jumping right in there then, because a lot of times what you're going to see is with these patients, especially the teen patients that do a lot of that, you're going to see, just hypertonic, sternocleidomastoid, kind of all these front muscles because they're always pouring forward. And believe it or not, when they're sitting slumped and they're forward, and I can do that right now. So if I slump and I'm forward and I take my thumb on my sternum and my pointer finger to my chin, and I might make one change here and I just align my pelvis and bring my pelvis to neutral, what position have I been sitting in? Not only the forward translation, but also some extension here. So when I come back down here, and these kids tend to be here or here, kids, not even kids, adults, and that's a lot of pressure over time on the nervous system. So you want to, really correct that. But again, I'm super, just very strict about working at the lower level. Even if they're just sitting patients or in a wheelchair, go ahead and correct at the pelvis level, because the pelvic at that point is that's your primary foundation. So like I said, I just did that where all I did was change my pelvis, and look how that changes my neck position to this, and all I'm doing is changing the pelvis. So really working on posture for these patients is big. Working on cervical stabilization, looking at proprioception, how you can put a head laser on the patient and make a little target out of sticky notes on the wall if you wanted, and look at their quality of movement. How are they moving? And if they're sitting in a poor position and they're doing this, okay, so if I just slump over, I can be an owl right now, because if you take an x-ray vision of my cervical spine or my spine, it's going to be like a staircase as opposed to a nice stacked curve that we should have. So if I sit here like this, I could be an owl right now. I could turn my head. Like I said, I live with all of this, but I have a lot of range of motion. I'll just show you my rotation. I can even go further. But if I fix one thing and align pelvis, restore my curve, so I'm giving myself my cervical curve, and I'm putting everything in alignment here. Now, here is good quality movement. This is as far as I can rotate without pushing myself into a further stretch. I had no stretch going back there because now I'm getting an accumulative, range of motion by all of those levels, but it's very dysfunctional and it's not protecting your nervous system. So that's where you have to jump in to do all of those things. You could do other things. You could look at the NASA lean test if they're having a really hard time with their orthostatic intolerance or POTS. You can look at even on the very, very low irritability statuses with some of these patients that are just hypermobile. You're not hearing like a big history of anything. You could go in and do some ligamentous testing if you wanted to. I don't think, as long as you know that they just have a hypermobility background, it's not this big neurological, you can get in there and test the integrity of their ligaments in a very gentle fashion. I tend to not do that as much. I just jump in, and they're going to benefit from posture anyway. I already know they're hypermobile, and when your C1, C2 is your most hypermobile segment of your body to begin with, and you plop a 12-pound pumpkin on top. I mean, come on, we all need that. We all need that education. So that's pretty much what I do when I'm looking at the history and physical, and then I move right into education while I'm doing that. We're going back and forth as I learn about them, and I decide how much I want to do physical exam hands-on wise. And I want to hear that they are a low irritability status, maybe then have them do some movement with moderate, but that's kind of where I go with that. So.
Yeah, I know, from the kind of neurosurgeon perspective, and none of us are those, but, the testing that they do to sort of confirm these sorts of diagnosis with the help of a physical therapist is, the upright MRI that does the flexion and extension. where you're measuring, like, are you within kind of normal range, and there's the CT, rotational, I can't think of the words, where you're turning your head to the right and the left, and that helps you identify from testing from a neurosurgeon's perspective, and then the data that you guys can help put together on levels of function are really important to determine, what should you do about surgery. So say you get diagnosed with, CCI or one of the AAI, one of these conditions, and you want to go do your best to avoid surgery. You want to work with a physical therapist, obviously one who knows about hypermobility. Do you have any suggestions on like how to find this kind of, physical therapist? Because I mean, you guys are rare as well. Or, what could we use from your paper to educate our existing physical therapists on like, what to do? Leslie, what do you think about that?
So I always advise people to check the healthcare providers directory on the Ehlers Dominos Society webpage. So they do have a site that has a list of doctors and therapists who are EDS knowledgeable. It's not a very comprehensive list because people who aren't involved in the Ehlers Dominos Society tend to not post themselves. So just because somebody's not on the list doesn't mean they're not good, but that's a really good starting place. And often if you can find one person in your area who's knowledgeable, they can connect you with other people who are knowledgeable. So sometimes people will ask me, well, how do I find a good doctor? It's like, well, if there's not a doctor on the EDS Society page, but there is a physical therapist, contact the physical therapist and ask if they know a good doctor, because, we tend to know who's around us, who's knowledgeable. If there's nobody listed, then contacting the therapist and asking, are you guys knowledgeable about Ehlers-Danlos syndrome? I recommend using that term rather than hypermobility, because all PTs think they're knowledgeable about hypermobility. It's like, oh yeah, I can treat a hypermobile shoulder or a hypermobile knee. But Ehlers-Danlos at least helps them to understand that, no, we're not just talking about, one unstable joint. We're talking about a person who has a whole connective tissue disorder that affects all systems of their body. And then networking to find the good providers. So the neurosurgeons, for example, there are probably 4 in the country that are really knowledgeable about EDS. And so finding out who those people are can be, a matter of networking through either therapists or the support groups.
I was gonna say, I know the support from the community of how we, jump in and collaborate and help each other has been really instrumental in my patient care. Sorry, I didn't mean to interrupt. Go ahead, Susan.
Well, yeah, and that's what I was going to say too. These social media, you have to take that with a grain of salt. How credible it is, but just watch it. If you're hearing what you want to hear, and there's patients out there posting. Sometimes you can connect with somebody and you can start. You can private message them and ask them what their experience is, if you like what they posted or what they heard, and could they connect them with somebody else. So with my telehealth, and I treat patients all over, that's the problem, is everybody doesn't have access to be able to get on an airplane, especially if there's, have a severe case and they're severely irritated. They're not going to be able to travel like that. And it is very difficult to go to find somebody who is knowledgeable in this on the neurosurgery side. Who you want to find somebody, if you're going to question them, do they understand hypermobile EDS, and and kind of interview them, and even if you do get a name off the Facebook page, then again, interview your doctor and talk to others on these sites and educate yourself. I mean, my patients have done by the time they get to me, a lot. I'm actually surprised how many are so educated, more so than my uneducated ones. And it's kind of like, I sometimes am used to my patients being extremely educated and knowing who's in the area and who's doing what. And occasionally I just have to step back because I start at this level and I have to go, okay, now I got to come way back here. Really, and I really like to do that. I mean, I really enjoy doing that. And I like to kind of come in and say, okay, so you live in this area. Let's talk about, providers in that area for these problems that I am hearing, because we've got to get medical under control as well to be able to participate in physical therapy, at some point. And really it's just, that's only if your mast cell's out of control, POTS is out of control. We can do so much. We can still do education at those levels, but still to progress with physical therapy, sometimes we have to have that intervention. So we have to find a specialist that is close enough to be able to get to them. So yeah, again, just finding that one PT or that one doctor that's knowledgeable, or a few people, in your community that are living with the same things, and just sometimes if there's not many people and you don't know much, you just got to start somewhere, and you have to do some interviewing of, your healthcare providers to see what they know.
Yeah.
Yeah.
And I've heard from some of our co-authors in England and Australia that patients are bringing the article in with them to their therapist and saying, okay, this is what I think I have. It's like, are you familiar with this? And so patients are being proactive about helping to educate therapists that might not be as knowledgeable. And I think that's been a huge force. And I think that's why the articles had so many views, is patients being proactive. And as you said, Christy, that the article is pretty user friendly, that patients can follow along with it and make sense out of it. And so I think we've got a lot of really proactive patients.
Yeah, I mean, the paper is fantastic in terms of going through, like, these are the symptoms at those like different levels that you talk about, and the yellow flags, and then like the red flags to watch out for. And we're not necessarily talking about it on this call today because they can go and read it. And the patient guide that we're going to share is very clear about, the symptoms, and, the sort of be cautious not to do, these things. Like, for example, a PT might have you doing chin tucks, and that might or might not be something that irritates you. So I highly recommend anybody that's watching this that you go and read both the paper and the patient guide. And I thank you for your time. We're running out of time. I wanted to ask you any other kind of like self-care or maybe lifestyle tips, or, any kind of tools or resources that you ladies would recommend to people that are, in the middle of trying to figure this out.
I want to really emphasize what Susan's talked about how important it is for patients to take care of themselves. Those little things like slumping or reading your phone, that those things really accumulate. If you spend 8 hours with your head tipped forward, I like the image of a golf ball on a golf tee. You've got this big golf ball on a golf tee, and if you tip it this way, the golf ball's going to slide off. And that 12-pound pumpkin is going to slide off. And so it's really important that patients are doing things to take care of themselves, and not just count on the therapist or the surgeon to fix them. Because if you're hypermobile, you have to learn how to take care of your body and protect it.
Yeah, I do. I wanted to say, I do tell my patients, like when they're new patients, I tell them it's management for your lifetime. So you're going to start with one thing at a time. We can go as slow as you want, and you need to get a hold of each one of those components to be able to progress, because there's a lot going on here. But again, I tell the patients, I am not here to fix you. I'm here to teach you what you need to do to be able to better manage, your alignment, your posture, protect your neurovascular system, protect your discs and ligaments. I mean, as you age, it's going to wear and tear anyway, even if you were normal. So, just think of the acceleration with the fragility of what we have to deal with in our bodies. And so it's even more important for us to be more aware. So we have to be more aware than normal people. We have to be more aware of our alignment. We have to be more aware of, correcting ourselves. And believe it or not, the more that you know what to do and know where to go, and you have your gold standard of, oh, this alignment is going to take pressure off my nervous system because I'm aligned, and, my posture is good, and my ligaments are, not on stretch, and my discs are, you know, and jelly donuts are happy. My disc pressures, I'm not stretching my neurological system or my neurovascular system. I'm stacked, right? So the more that you're more aware of that, it's this loop of your muscles are going to become more conditioned. But when we get tired and you fatigue, you're going to kind of fall out of that. But that's going to be your cue that, oh, my posture's bad again. So here I am aware again. So now I need to put myself back. And if I can't put myself back and hold it, then I'm fatigued and I need to go change up what I'm doing. So it's really in your mind, just knowing what to do next to protect. But you will learn this increased proprioception, awareness of where you are in space through, you know, and then you'll have this heightened awareness just in general, and your triggers may be a little bit of discomfort or pain, but we hope that, you know, you're just catching it before any of those symptoms come on, and you're just aware that you're losing your posture, and then you're making a change, because this is, again, for the rest of your life, you know. So it's not easy. It is hard work. The patients do have to put the work into it. And I do have a group of PTs around the US that reach out to me and say, hey, I'm seeing a lot of this. And if I hear that these PTs are very interested, we have an EDS echo program where we've got the PTs from anywhere can join our program, and they're Leslie, you can even bring that up a little bit, but I mean, there are ways to educate. If they have that interest, I am all day long all about helping that PT to further their education on that. And, you know, hopefully by the end of this year or sooner, we will have, you know, a PT module kind of training program to help these patients or these PTs learn more to help these patients. And it's not only the EDS patients, this helps everybody, you know, in general, to increase their awareness and their alignment and their posture. We can all benefit from that. So
I would say it's a great collaborative effort of everybody coming together to try to, you know, raise awareness and knowledge. And, you know, it's like you're saying, everything from small lifestyle self-care tips. Like, I love your, you know, belly button rule, where it's like, you know, keep things kind of like in front of you. Yeah. Like keep yourself aligned, and, you know, simple things like that not everybody knows. Well, I'm so grateful for your time today. Anything else you want to add before we sign off?
No, I think your questions have covered it.
Great. Well, the real resource is in your paper, the article, and in this patient guide. And so make sure anybody that's a patient or a PT that's interested in learning about it, that you access those resources that we're going to have links to. So thank you both for being with me today. And, you know, fingers crossed for a good repair of the spinal fusion at my UCI.
Yes, good luck.
And look forward to seeing you on the other side, Susan. And you guys take care of yourselves and your patients, and be well.
You too. Good luck, Christy, and let me know if
good luck.
Thank
I
you.
can help. Okay.
Yep. Bye.
Bye.